Let us go to the next question in previous year NEET question discussion of NEET 2025 cardiology. So as usual, we'll start with the last line. Which of the following is the most appropriate preventive treatment? So a diagnosis has to be picked up and we have to tell about the preventive treatment. Okay. So a patient arrives at the emergency department with sudden onset palpitation. So when it is palpitation, remember we are having some arrhythmia and chest tightness. ECG confirms the diagnosis of PSVT. So sometimes they may give an ECG. If an ECG is given with this history, palpitation, chest tightness and arrhythmia history, high heart rate, just you have to see two things. Obviously when there is tachycardia, the ECG is going to be fast. You are just going to see the QRS complex. When the QRS complex is narrow, so see this case, narrow in the sense this is narrow. It looks narrow. Plus the actual way to say narrow is the entire QRS duration is less than 3 small squares. I am not telling the actual values because when the ECG is given, we are obviously going to count the number of squares. When the QRS duration is less than 3 small squares, we call it as narrow complex. So when there is a tachycardia or an arrhythmia with narrow complex, it is called as narrow complex tachycardia. Similarly, when an ECG is given with the wide complex, see this one looks obviously wide. To say wide, the QRS duration should be more than 3 small squares. This is obviously more than 3 small squares. So when there is a tachycardia or an arrhythmia with wide QRS complex, we call it as wide complex tachycardia. There are some arrhythmias which are narrow complex tachycardias. There are some arrhythmias which are wide complex tachycardias. Remember, anything which is above the ventricle, supraventricular origin is supraventricular tachycardia. They are narrow complex. Anything which originates from the ventricle is wide complex tachycardia. Example, ventricular tachycardia, ventricular fibrillation. They are wide complex tachycardias. Anything which comes above the ventricle is commonly labeled as supraventricular tachycardia. There are many types like atrial flutter, atrial fibrillation, the so-called AVNRT. Common SVT is AVNRT and atrial fibrillation. Okay, so we are not going in detail. Atrial fibrillation, we have the clue, right? We have already discussed a question on that. Irregular heart rhythm. Atrial flutter, the ECG shows a peculiar pattern called sawtooth pattern. Okay, when you have time, please see the ECGs. It will be easy to recognize as a last minute revision in it. But when common term SVT or PSVT, paroxysmal SVT is used, it stands for AVNRT. So similar to these terms, in wide complex tachycardia also we have ventricular fibrillation, ventricular flutter and ventricular tachycardia. The treatment for both is different. Okay. So here ECG is not given. So we don't have the burden of differentiating wide complex tachycardia versus narrow complex tachycardia. They have directly given the diagnosis is PSVT, paroxysmal supraventricular tachycardia. So it has to be a narrow complex tachycardia. Which of the following is the most appropriate preventive treatment? Okay. So we have options. IV lignocaine. Remember, lignocaine is a drug for treatment of ventricular tachycardia. It has no role in SVT. Next option is verapamil. Remember, verapamil is a non-dihydropyridine calcium channel blocker. You remember we told about the terms ABCD. B is beta blocker. C is calcium channel blocker. In arrhythmias, non-dihydropyridine calcium channel blockers of verapamil and diltiazem are only used. Whereas dihydropyridine calcium channel blockers like nifedipine, cilnidipine, amlodipine are used in hypertension. The D stands for digoxin. Okay. I told you when discussing atrial fibrillation, there is no role of A in atrial fibrillation. A stands for adenosine. Adenosine is the drug of choice. For treatment of AVNRT or PSVT, paroxysmal supraventricular tachycardia. So how will you treat PSVT? It is not directly adenosine. The first step is vagal maneuvers. Vagal maneuver is like pouring cold water in the face, immersing in face, and blowing out air. So there are some maneuvers called as vagal maneuvers. You need not remember everything. When vagal maneuvers fail, we have to use the drug which is adenosine. Okay, when adenosine fails, we are going to use electrical cardioversion. This is how you treat PSVT. But the question asked here is how will you prevent, right? Again, we are going to give one of the drug. Adenosine cannot be given as prevention because it is an IV drug. Okay, beta blockers may be given, but calcium channel blockers are more effective than beta blockers in this case. Digoxin, even though it is a good drug, it is not commonly used nowadays because it is prone to cause digoxin toxicity. If some question comes giving an ECG mentioning a inverted tick sign, right? So there is something called inverted tick sign, which is a depressed ST segment with a T wave inversion or a hockey stick sign. It is a sign of digoxin toxicity, right? So since the probability of digoxin toxicity, digoxin is not used nowadays. So among beta blocker or verapamil is commonly used as a preventive treatment for AVNRT. That is what this option is. So oral verapamil seems a good option. Again, always in NEET, we have to read the other options before coming to the conclusion. IV adenosine, as I already told you, it is the treatment for AVNRT used as a second line when vagal maneuvers fail. Oral nifedipine. Nifedipine is also a calcium channel blocker, but it is a dihydropyridine calcium channel blocker used to treat hypertension and not used to treat arrhythmias. So lignocaine ruled out because it is the treatment of VT. Verapamil ruled in because it is a arrhythmia treating calcium channel blocker. Adenosine ruled out because it is the treatment of AVNRT. Nifedipine ruled out because it is an antihypertensive drug. Okay. So in last 2025 NEET, some 2 to 3 questions have come on arrhythmias itself. Like we had a cardioembolic stroke with AF, and we had a treatment of AF, acute treatment of AF, and we had this SVT. Okay, so just summarizing about arrhythmias, we have supraventricular tachyarrhythmias and we have ventricular tachyarrhythmias. Supraventricular tachyarrhythmias are atrial flutter, atrial fibrillation, and PSVT. Ventricular tachyarrhythmias are ventricular tachycardia, ventricular fibrillation, and ventricular flutter. Opposite of tachyarrhythmia is bradyarrhythmia. We have sinus brady. We have atrioventricular blocks. If some questions come across, we'll be discussing that. So please be thorough on at least arrhythmia, a few concepts, right?